Hi, my name is Dr. Angela Wingfield. I'm a board-certified dermatologist. I practice in a community dermatology setting in coastal Mississippi. Been in practice for 20 years. We have lots of patients here who've had tons of sun exposure and skin cancer, so we see a lot of melanoma in our practice. I also supervise 5 physician assistants, so we have a large patient volume. And we use the Castle melanoma test a lot in our practice to help us with management decisions. So I picked out a few interesting cases that we had just to illustrate some points. I hope you enjoy the cases we've chosen. So our next case is a patient, he's a 70-year-old male. He had a lesion on his left lateral calf. If you look at the photo, you can see it's mostly pink, but there is a little bit of pigment at one edge. This is a patient who's had multiple basal cell carcinomas over the years. I see him every 3 months and take 2 or 3 off typically. So we kind of thought this might be a pigmented basal cell, but to our surprise, which is why you do the biopsy, it came back as a malignant melanoma. And the depth was deep. It was 1.5 millimeters. And so that's unusual for something that has just been there, a short period of time. So it made me really worried about him. There was no ulceration on the pathology report, and the mitotic rate was 3 to 4. So pathologically, the stage was PT2A. In our clinic, we routinely do the Castle DecisionDX test for melanoma on anything that's deeper than 0.3 millimeters. So luckily, that was already kind of in shipping and on its way to getting a report. And it came back, luckily, as a 1A, which is always my favorite result to get. And so it really helped me decide with this patient who's 65 years plus, right? He's a 70-year-old man. We can really think about whether this person needs a sentinel lymph node exam or not. Even at a depth of 1.5, a patient who's older than 65 with a 1A has a very good outcome. So I did have the discussion with him, and we decided that it was probably overkill to do a sentinel lymph node biopsy. So I just excised that primarily in my office. And because he's a 1A, I did not offer him any imaging. Sometimes I do offer imaging, but not with 1A patients. So now we are 2.5 years out on this case, and we do follow him closely, but we were already doing that before because he comes every 3 months to get multiple other things removed. So he's done well now at 2.5 years, and we're excited to keep following him along. But this is a good illustration, I think, of a patient over 65 with a deep melanoma, but with a very good Castle score that's going to have a good outcome. So our next case is really an interesting case all the way around. It's a 42-year-old female who presented with, as you can see, this sort of firm, kind of nondescript flesh-colored bump on her arm. It was really not concerning for anything, but she said it was getting bigger. It didn't look like much clinically, but whenever we can't really put a name on something and explain why it's growing, we usually just biopsy it. We did biopsy it, and it came back very surprisingly, honestly, as a malignant melanoma, and it was 1.9 millimeters deep. So that's a deep one. It was not ulcerated, as you can see in the picture. It didn't look like it was ulcerating or bleeding. The mitotic rate was 3. It was positive all the way to the deep margin. So 1.9 for sure, but it was deeper than that. Pathologically, it was a stage PT2A. This one was really sort of caught us all by surprise. Because of her age, she was actually 40 years old at the time of the biopsy, and her level of anxiety. This patient is so anxious about everything in general, and this really sent her into a tailspin. I said, look, we're going to send you for a sentinel lymph node. You're young and you have a very deep melanoma, but I also want to get this Castle test because I want to see what your risk factors are going to be genetically. She did have the sentinel lymph node done, and she had positive sentinel node. That was concerning, obviously, which bought her a ticket to the oncology office. But still, I'm sitting there waiting for the Castle test to come back, and it came back as a 1A. I'm trying to reconcile in my mind how this deep lesion came back with positive sentinel node, and it's only a 1A. And I really think what's going on with this case is that it started deep in the dermis. In fact, the pathologist called me with a concern that it might be a metastatic lesion because she did not see really any connection to the epidermis, and all of the action was pretty deep in the dermis. And so she was worried that this was like a cutaneous met from another melanoma. I think this one must have started deep in the dermis to begin with, and it took a while for us to see it on the surface to become that bump that we were looking at because it had to push so much tissue upward to get some attention. So I think the reason it ended up in the lymph node is because it had probably been there a long time, but that it wasn't particularly aggressive necessarily just because it was deep like that. We did go ahead, the oncologist decided to go ahead and just, get a PET scan, of course. There were no other foci anywhere, which was nice and reassuring. But of course, it's a very nervous patient who's got 3 young kids and she's young herself. They did decide to go ahead and do a year of Opdivo for her. And so she finished that almost a year ago now. And luckily she didn't have any side effects with it or any of the autoimmune problems. We do follow her closely, and we biopsy tons of things on her. Anything new gets a biopsy because she's so afraid. But I told her that when we got that 1A back, that it made me feel so comfortable that we were, that everything was going to be fine and that she was going to have a really good outcome. And so I follow her, and oncology follows her. But luckily there have been no events and nothing has shown up on her PET scans, and we're almost 2 years in now. So this is a really kind of interesting case just because of the presentation, but also another one of those where the Castle test really did help us make some decisions. Our next patient, I don't have a clinical photo. She was referred to me after her surgery was completed, so I picked up her care. But she was 67 years old when she presented to me. She had come from a general surgeon who did her excision with sentinel lymph node studies. And her melanoma, which was on her shoulder, sort of upper arm area, was 3.7 millimeters deep, which, makes everyone's heart sink when you see a report like that. And of course it was ulcerated and the mitotic rate was 8 and it had lymphatic invasion. And all of those things just make you think this is going to go very poorly. Her sentinel lymph node was negative. She ended up becoming a stage 2B after that surgery. But I knew when I saw her immediately that this was going to be bad. And so she was a person who was sort of a denier and decided that because sentinel lymph node was negative, that she was going to be fine and she was going to put her head in the sand. I went ahead and ordered the Castle test so I could try to use that as some information to help me guide her. And of course, I know, not a shocker, it came back as a 2B, which is very high risk. And so I tried to use this information to convince her to get a PET scan. That's all I wanted her to do, was just get some imaging, because I felt like this thing has probably already spread. I mean, literally it had lymphatic invasion on the, biopsy. So she refused, but said she would think about it, and then ended up returning again in 6 months for just another skin exam. And at that point, I had been thinking about her on and off in that whole time frame, just knowing that something bad was going to happen. I told her, look, if you don't get this PET scan, I'm not going to be able to sleep ever again. You have to get it. So I kind of guilted her into getting a PET scan just to see what was there. She ended up having some pulmonary mets on that scan. And of course, then I got oncology in on the game. But she delayed herself multiple times to get to the oncology appointment. She really, really did not want to believe what was there. They finally got her biopsied and proved that it was metastatic melanoma, started her on chemo. She went through 4 different types of regimes. She kept getting new mets on the next scan, kept getting a new area. One would shrink, one would get bigger. And it just sort of, devolved into finally some brain mets. She made it about 1.5 years after I met her. And this case just breaks my heart because I know if she had the proper care maybe from the beginning, and we had known right away that she, you know, obviously needed some more treatment, and she would have, you know, complied with it, that she would have had such a lower tumor burden and probably would have done much better on all of the new medications and immunotherapies that we have. And so I know you can only do as much as the patient will let you, but I still feel like I should have been more emphatic with her and tried to get her scanned sooner and all those kinds of things, just to see if she could have had a better outcome. This one was one that did not turn out well, but as soon as I saw her original path report, I knew it was going to be a battle. Sometimes we use the Castle test just to give us some more emphasis, or it was the only thing that I could get her, you know, to get a scan with. So sometimes it's one more piece of information to try to make something hit home for a patient so they can kind of understand your level of worry about them. Our next case is an interesting one. This was a 52-year-old man. He presented to us with a pink nodule, as you can see in the photo, on his preauricular cheek. Of course, it was biopsied, and it came back as a malignant melanoma. The depth was 1.5 millimeters. So that's a pretty deep lesion on the face, especially, and it was ulcerated. The mitotic rate was 4. So we immediately got him to an ENT who does sentinel lymph node based upon that depth and his age. And the sentinel lymph node was negative. So that's kind of interesting. We were happy to see that, but the node bed is right there. And we thought, okay, he's young. We definitely need to make sure we get the Castle test just to see what else is going on. A lot of people would just sort of leave it at that. The sentinel node was negative. We'll just follow him. But those clinical, you know, the depth and that ulceration really kind of made me worried. So we did get the Castle melanoma test, and it turned out that it was a 2B, which is not that surprising based upon the depth and the ulceration. And so we used that information to go ahead and get some imaging for him. So we got a PET scan, and he had an area light up actually in his parotid gland. We ended up sending him back to the same ENT surgeon. He was so freaked out by it. He removed that focus, but he also took out several more lymph nodes in the neck while he was there, just because he was so nervous. After it came back, there was a positive MET to the salivary gland. There was nothing else in all of the other nodes that were removed. And we got him into oncology. He was treated with Opdivo and Yervoy initially, just for 4 sessions, and now he gets monthly Opdivo and some very close follow-up with oncology. He is about a year out now, so he still has a little ways to go here, but so far his scans have been clear otherwise, and he does not have any distant mets out of that little region. So this was a case where the Castle report really helped us just to go ahead and get the imaging that we thought we needed, because he was a 2B, and then find an interesting place for the metastatic disease. But he's done well, and I think it's because we found it early and that we got on it, and he's on his immunotherapy.